Good evening, everybody, and welcome to the IOCP's latest webinar on nails, structure, pathology and treatment, the sequel. Your host this evening is Martin Harvey, and before I hand you over to Martin, I just wish to advise you that this webinar is being recorded, and also if you would like to ask any questions, please do so by putting these in the chat box. Thank you, and I'll pass you over to Martin. Thank you.
Well, thank you, Jill. Is my sound okay?
Perfect, yes.
Excellent, thank you very much indeed. Well, good evening, everybody, and welcome to a very, very warm, very sunny Derbyshire. So I do apologise if my picture isn't very good. I mean, my picture isn't normally very good anyway, because it's got my face on it. But in this point in time, I've still got the sun shining through the blinds. So if the picture's a bit washed out, you're not missing much, you're only missing my face. But hopefully what you will see on your screen is a screen share of yet another presentation on nails revisited again, part 3. I don't know how long we're going to keep revisiting nails, but of course, there's such a huge subject, we might still be doing this by the time I retire, in which case I'll have to pass it over to somebody else. So, nails yet again. What I'm going to try and do on this one is to concentrate on the treatments. Now, obviously, there are multiple treatments for nail problems, far more than we can possibly cover in an hour's webinar. But nonetheless, I'll be talking mainly about the treatments that I'm familiar with. Now, some of you may be familiar with treatments that I'm not familiar with, because there are a whole raft of them that do exist. Some are based on science, some are based on hope and trust, and some are based on folk remedies. I mean, there is a folk remedy about mashed up earthworms in butter that you leave to rot for a month, I believe, and then you smear the paste on the toes, and it is supposed to cure fungal nails. I've never tried that. If any of you do wish to try it and then report back, then just please send the information to Jill or Kirsty, and we will share it. And if you want to send some samples, probably don't send those to Jill or Kirsty, because I suspect it's probably illegal to send it through the post. And also you may cause the rapid demise of the poor people who actually open it. So without further ado, let's start doing some things. Now, here we go. So you'll recognize this slide from the introductory slides of the other presentations that I've given. Nails, nails, nails are a window in physiology. They're an indicator of disease. They're an indicator of toxicity and many other things. And I'm quoting from Dorber, Barron and de Burker, Science of the Nail Apparatus, published in 2001, which is my go-to book. And no, I don't get a commission for pushing this book. The only reason I keep mentioning this book is because it's absolutely fantastic. Anything you need to know about nails is in there, and probably a lot of things you didn't want to know about nails as well. So in parts 1 and part 2 of the talks that we've had, we looked at the developmental anatomy of the nails, we looked at the morphology of the nails, the physiology of the nails, types of infections affecting the nails, and also systemic diseases affecting the nails. Now, it's all very well, realizing the fact and spotting the fact that there's something wrong. You then actually, we as practitioners, hopefully have to do something about it. Now, the toes that you can see there, I'm sure at this point in time, the majority of you will recognize them. They are the toes of somebody who had COVID, and this appeared after the COVID. Now, they're a very young person. Well, by young, they're in their 20s, which to me is young. And they've never had chilblains. Obviously, these do look to a certain extent like chilblains, but bear in mind, this wasn't in chilblain weather, and these were almost within a week of being diagnosed with COVID. I think 2 weeks of being diagnosed with COVID before I actually saw them. So I think we can probably fairly accurately assume that those are COVID toes. Whether that will actually result in damage to the nail roots and therefore damage to the nail structures in time to come, of course, we don't know at the moment. It's one of the imponderables. But at some stage in the future, we may possibly be discussing what COVID has done to somebody's toenails. So that's just something I put there for the future. And also, I put these up to open our talk, to open our chat, because it's not strictly a disease of the nail, but I'm sure that more than a few of you will actually have seen this on somebody's toes, or if you happen to look at fingernails as well, sometimes they're fingernails. By the end of this presentation, I would hope that a few people would be able to suggest what we're actually looking at here. Obviously, we are looking at it through the vagaries of computer screens, so perhaps the colors are not as good as the colors could be to make an accurate stab at a diagnosis. But what I can tell you, and you can probably see it slightly more clearly on the hallux, on the big toe, to the left of your screen, that has had nail surgery at one time. As you can see, it's had a partial nail avulsion on both sides of the nail plate. It's got a decided green tinge to it. But what I will say is it's not a fungal condition. So perhaps in the chat box, by the end of our talk, we might see somebody come out with an idea of what that is. And I don't know, are we going to give away anything for that, Jill? If somebody gets it right, the first person out the box? Jill's gone deathly quiet. It's because
Sorry,
it's because I suggested giving something away.
I fell off my chair.
Even if it's only an Institute t-shirt or something like that. Very good t-shirts, actually. I've got a couple. But anyway, that is not a fungal condition of the nail, but it's something that you can encounter fairly frequently from time to time. Now, some infections, and you might see a clue here, some infections are bacterial infections, but bacteria do not essentially infest the nail itself. They do infest around the nail, and they can complicate things. So normally a bacterial infection is usually periungual, so it affects around, or, and here's another clue, under the nail plate. And bacterial paronychia can be caused by a whole variety of bacteria, Staphylococcus, Pseudomonas aureus, etc., etc., etc. If you ever do encounter paronychia, an infection around the nail, then the simplest way to try treating it in a very old-fashioned way that certainly your doctor would have suggested 40 or 50 years ago would have been a fomentation. Nothing to do with foam, but it's how they used to describe simply a hot compress placed on the offending part of the body that they wanted to apply a fomentation to. So it's simply hand hot water applied as a compress 3 to 4 times a day. Why that should particularly help paronychia, I don't know, but it certainly was a staple of treatment before we had some of the more effective antibiotics that we have now that can actually help the condition. If the fermentation doesn't work on bacterial paronychia, then a broad spectrum antiseptic solution, for example, halogenated phenol in warm water, can be applied, once again, to bathe the area in. Halogenated phenol, of course, is good old TCP. Antibiotic ointments in more refractory cases can be applied. Now, of course, those are prescription-only medicines. I've given 2 examples there that I frequently need to prescribe. The first one is fusidic acid cream or ointment. You've got the 2 variations there. Obviously, a cream is more water-based, an ointment is more grease-based, and they have different characteristics of how long they stay on the skin. The trade name of that is Fusidin. And there's the trade name of Bactraban, which is mupirocin cream or ointment, once again. So you've got either the water-based or the greasy one. And both of those are quite effective. Now, of course, because the prescriptions that I write outside of the National Health Service are private prescriptions, the good news for my patients is those are remarkably cheap. You know, they'll pay a pharmacy a £5 or something for a course of that. So they can be quite effective. As with anything like that, of course, you do have to give people instructions on how to use it. So fusidin cream is 20 milligrams to the gram, and that can be indicated either alone or you can combine it with a systemic therapy. You can use it for primary and secondary skin infections around the nail caused by strains that are sensitive to whatever cream you've chosen. And it can include a little picture that I put there of dear old Corynebacterium minutissimum. Now, it's quite rare that I can actually get that out in one go. So I'm quite proud of the fact that I was able to say that today. But that's Corynebacterium minutissimum illuminated by ultraviolet. So that's from a simple ultraviolet lamp. You may be familiar with them as Wood's light. So it's the traditional black light that causes a fluorescence of certain items that it shines on. For example, in this case, Corynebacterium minutissimum, which grows quite a nice red color. And it is a definitive diagnosis of it. If you're applying fusidic acid, they need to be uncovered. So apply 3 to 4 times daily if it's an uncovered lesion. If you cover it, then obviously you need less frequent applications. They may be adequate. But as with anything, be it a steroid cream, be it an antibacterial cream, then apply it quite sparingly. There's a few warnings and precautions you have to take if your patients have got hold of, or if they have been prescribed fusidic acid. The extended or recurrent use might increase the risk of developing contact sensitization, which essentially any topical agent can do. As with all topical creams as well, it does contain a whole load of excipients which contain the active ingredient. And some of these excipients, such as, and I'm going to try and say this one again in one go, butyl hydroxyanisole, which is kind of a preservative, that can cause skin sensitization as well. So on the one hand, you can be putting something on that will help the condition. On the other hand, it might be putting something on that will make things a lot worse because they'll develop a sensitization condition. And also, strangely enough, fusidic acid cream or ointment especially, if it soaks into fabric, say bedding or socks and things like that, it does make them fiercely into a fire hazard, essentially. They can catch and burn. So because we don't want to burn our patients to the ground, it's probably a good idea to warn them about that. Why this particular mixture is so fiercely incendiary, I have no idea. But if any of you are pharmacists, I would be very interested to know the answer to that. Bactraban, very wide spectrum antibiotic. It's active against Staphylococcus, methicillin-resistant strains as well, quite unusually for a topical agent. Other Staphylococci, Streptococci, and it's active against gram-negative organisms such as E. coli, Escherichia coli, which, as you know, comes from the gut. And of course, when it comes from the gut and perhaps people's bathing habits are not as rigorous as could be, then a lot of the products from that can end up on the feet as well if they're not swelled off properly. And interestingly, once again, for medicine, this one, Bactraban, is licensed for children, infants, and adolescents. Anybody essentially aged 4 weeks or older. And virtually no medicines that we use on a regular basis have such a low license age. So it's quite a handy thing to be aware of if somebody brings little Johnny or Jenny into your surgery and you need to treat them with some type of topical antibiotic agent, which you either, if you're a prescriber yourself, you prescribe, or if necessary, you obtain it through the good offices of a prescriber, the local GP, or indeed if you have a local prescribing podiatrist or nurse, for example. So it's got warnings and precautions. I would imagine that some of you will have this as will want this as a download. So a lot of the slides, and I must apologize for this, a lot of the slides are quite busy. There's a lot of information I'm trying to get over here and cover. So very busy slides. So I don't propose to read everything off the slide, but the slides are put there as an information resource for you. So essentially, if you want to have a copy of the presentation as a PDF, then you can read through things like the special warnings and precautions, etc. Obviously, special warnings and precautions will be found in the British National Formulary and e-medicine and things like that. But it's a good idea to be aware of it, because some of them, for example, mupirocin does have a fair few special warnings and precautions that's worth reading before you use the stuff. Now, let's come to probably the star of the show today, which is diseased nail plates themselves, because of course the bacteria isn't in the nail plate. The bacteria is in the soft tissue that the nail is sitting on, or around the nail. Now, of course, that can be sufficient, going back to the bacteria, to perhaps loosen the nail plate, simply because of the effect it has on the soft tissue. But if we now come to diseases that actually affect the nail plate itself, this wonderful keratin meal that fungi has, when it looks at a nail, it must think, wow, it's like going to McDonald's or something, because it really is a good source of nourishment for them. Now, the antibacterials that I've mentioned earlier, of course, they won't work on fungi, simply because fungi are multicellular. They're eukaryotic cells, essentially. That's opposed to the unicellular type of cells that you get with bacteria. So it's the unicells that are a target for bacterials, antibacterials. But of course, the fungal cells, being eukaryotic cells, very similar to our own cells, they're that much harder to kill. So we have to work a bit harder. So how do we kill them? Well, a variety of ways. If people have got fungal nails, you can take them out entirely. You can remove them entirely. So nail avulsion, simple surgery. If you just literally anesthetize the toe, elevate the nail, roll it out of its compartment, its root compartment, then you can take the whole nail away. Problem is, if you do, and I'm just talking about taking the nail away, by the way, not destroying the cells that would then grow a new root. That would be for later. But if you literally just rip the nail out, then frequent problem is that you actually damage the matrix that a new root will grow from, and therefore a new nail will grow from. And you can then promote the formation of a damaged nail to follow on. A lot of us would have seen nails that have been damaged by trauma, where the roots have been damaged by trauma, and people have got nails that really are in a right old mess. So it's not perhaps an ideal solution unless there is a particularly good medical reason for doing it. You can, if fungi is infesting the nail plate, poison the fungi directly. Now, depending on the kind of poison that you use and the strength of the poison, it's obviously got an implication for the person who's attached to the nail. So you don't want to use something that will cause more damage than good. So there are, toxic agents that you can put on the nails, which will most certainly kill the fungal organisms. But if it kills the tissue that the nail is sitting on, might not be a good idea. You can interfere with the ability of the fungi to reproduce. So you can, for example, cook them. You can cook them with certain types of laser frequencies, certain types of microwaves. There are little microwave generators that you can do that will actually heat up these little fungal organisms. You can also try to destroy them with specific electrical frequencies. Any of you who use hyfricators or radiosurgery units, will be aware of the fact that we can pass a current through specific parts of the body, and that can be done, for example, through the nail plate. I myself have a radiosurgery unit that I use, and that can be set to either cut tissue using a high frequency current, or it can be set to actually cauterize tissue, literally heat it up to burning point so that you form a scar, or it can be put on a different setting and you literally boil the tissue that you're putting the high frequency current through. That's a specialist subject in its own right. I think we have in the past talked about electrosurgery, but it's something that some of you might be interested in. And if you are, I'm more than happy to do a little presentation on that as well. And then, of course, there's photodynamic therapy. Once again, many of you may be familiar with this. And this is where you disorganize the chromophores of the organisms that we're trying to disorganize with visible or invisible light frequencies, because all living things do have some of their cells that are specific to absorbing radiation frequencies. So, for example, the melanocytes in our skin. So when ultraviolet light shines on them, they'll produce more melanin. Hence, we get a sunburn, suntan, hopefully, before we get a sunburn. And of course, don't forget, there is a specific and very easily available photodynamic therapy, and that's sunlight. Excuse me, I haven't got COVID, I promise you. Actually exposing fungus or the fungally infected area to sunlight can hinder its procreation quite considerably. Obviously, you have to be careful telling people to habitually expose their feet to sunlight, because a lot of people then don't bother to put sunblocker on their feet, and sunburn on the top of the feet can be particularly painful, as I know. I speak having done that in my youth. So if we just briefly touch on nail avulsion, we've spoken that you can just rip the nail out, literally, which is what avulsion means, essentially. You can do a partial nail avulsion. Perhaps there might just be a streak of fungus down one side of the nail going down into the root compartment. Not unusual to see that. Then you could physically remove that side of the nail, and you could phenolize that section of the matrix of the root compartment with phenol, if you can get the stuff, which is in very short supply at the moment. Or you could use some of the alternatives that exist, which include electrosurgery, which also include things like sodium hydroxide, for example. We did a presentation on this in the last webinar that we talked about. So there are other things that you can use to ablate nail tissue, nail matrix tissue. Or you could do a Winograd procedure, which is one normally where you take a side of the nail away and you take some granuloma if it was sitting on it as well. And if that's, if fungus is implicated there, I'm not saying that fungus would cause granulomatous tissue, but if it was, that's a way of physically removing it without hopefully damaging the rest of the nail. Or you can do a total nail avulsion, and instead of just ripping the nail out and then leaving something that might regrow, a damaged nail or a partially damaged nail, you can do a complete removal of the nail root itself, essentially, where you open up the nail compartment with a couple of incisions to the side, you reflect the tissue, you fill it out, the nail and the matrix, the root itself, and then you abrade the little ridge on the distal phalanx that will be exposed at that point in time. You abrade that to remove any clinging root cells. Then you stitch the whole thing up, a couple of stitches on either side, and hey presto, they've got a place that should hopefully never grow a nail again. And of course, if they're never going to grow a nail, then hopefully they won't have a fungal infection on a non-existent nail. So probably if it was something that you couldn't get rid of in any other way, and if they were happy to lose a toenail, then that might be something to be considered. But of course, the thing to make clear to people is there's no coming back from that, unless you want to have a remaining lifetime of applying false nails to the top of your toe. Antifungal paints and similar. Now, I'm sure you probably, all of you, got your own ideas on antifungal paints. Now, there's a variety of things that have existed apart from the mashed up earthworms that I spoke about earlier, and I apologize if some of you haven't had your tea yet. But mentioned, 50, 60 years ago was a solution of copper sulfide, CuSO4. Now, that is actually used, and I imagine it possibly used today, if it's still permitted, in something called Bordeaux mixture, where you mix copper sulfate with lime and you dissolve it in water and you use it to spray fungally infected crops or crops that might become infected with fungus. So it's undoubtedly good for potato blight, but whether it's good for people, I don't know. As I say, it has been mentioned in some old chiropody texts Have I ever used it? No. Have I got the courage to use it? Probably not. No. But I just mentioned it in passing. I'll leave you to make your own mind upon that. And no lawsuits, please, because I can assure you, if there's anybody from the Health and Care Professions Council here, I don't use it. So if somebody does end up being hauled up, having put lime and copper sulfate on their toes, then it's absolutely nothing to do with me. But there's a variety of antifungal paints that are not quite as harmful as that, because there's lots of proprietary paints that exist. Now, probably the agent of choice is paints that contain amorolfine or amorolfine as a constituent of them. Sometimes with some of the makes, amorolfine is mixed with acetic acid, for example. Amorolfine is a very strange substance, because if you look at its legal category, then it can either be a prescription-only medicine, or it can be a pharmacy-only medicine, or it can be a general sales list medicine. And this is something that when I speak to podiatrists from other countries, they are absolutely bemused sometimes by our medicines rules. And I have to say, I'm bemused by our medicines rules as well. So if you look at amorolfine, then amorolfine 5% weight and volume medicated nail lacquer, available as a generic, so just an unbranded one, it's just the chemical name. It's available as a 2.5 ml, 3 ml, or a 5 ml presentation, and it's a prescription-only medicine. If you look at the proprietary one, Cure a Nail, then that contains 5% weight in volume, amorolfine, and it's a general sales list substance, which means that you could actually buy it from the shelves of your local supermarket. Now, strangely, the condition of the license for that general sales list is that you can only use it to treat up to 2 nails. So I assume if you do buy it from your local supermarket, what you'll probably have to do is point out to the lady or gentleman on the checkout that you're giving them a promise, perhaps in writing, that you will only use it on 2 nails. Whether they will know what the hell you're talking about, I have serious doubts, but that is the license of it. And then you have Boots Fungal Nail once weekly treatment, which strangely enough, again, contains 5% amorolfine. Now, that's a pharmacy-only medicine, which means you can purchase it from a pharmacy with a pharmacist, under a pharmacist's permission or with their direction, provided, of course, again, that you only use it to treat up to 2 nails. So if you intend to treat more than 2 nails, then it then becomes a prescription-only medicine, which is rather confusing, is it not? I don't intend to dwell on that any longer. I've highlighted the confusion. So to all of you, my best will in you sorting it out. But so essentially, amorolfine paint, probably that's my go-to when people want a nail paint. That's what I will suggest. However, there are all alternatives, some of which contain amorolfine, some of which contain all sorts of weird and wonderful stuff. And these are things that you can just buy openly on the web. So Nailner, and I know nothing about it, but you can buy that from Boots. You can buy Amazon's antifungal nail varnish. You can buy Shoals Get Ready for This Summer nail varnish. You can buy Protect Air fungal nail treatment, 5 mils. You can buy Premium Fungal Nail Destroyer, which contains argan oil and tea tree oil. Argan oil, I have no idea what that is, but possibly somebody can tell me. I don't know if there's such a thing as an argan nut. And tea tree oil. How effective tea tree oil would be on fungus, I don't know. There's some people swear by it. Other people say no. Once again, that's something for you to make your decision on. Do they work? Well, it depends who you talk to and what they're trying to sell you, to a certain extent, as it does with many things in medicine. Applying logic, once the nail plate itself has been manufactured by the nail matrix apparatus, the root, and it becomes damaged, because let's be fair, the majority of nail fungal infestations, I think, actually settle down in the root structure, so the nail grows with disease in it. There's a couple of exceptions to that, but in the majority they do. So once the root has actually grown a damaged nail, then you can put things on it until kingdom come. But you're not actually going to cure the stuff that has already been damaged. And this, I think, is what confuses some of our patients. They assume that once they paint a nail paint on it, a antifungal paint on it, that all of a sudden their diseased nails will magically become okay overnight. And of course, this doesn't happen, because it won't reverse the damage in the diseased part. So, that is something that some patients do have quite a bit of difficulty in grappling with the concept. They assume it's going to cure them overnight. And of course, it won't. Sometimes you'll have to apply nail paints for 12 months or more if you're going to do it. So damaged nail plates can be covered up with gels and cosmetic procedures, etc., which I'm sure many of you are familiar with. But can its physically damaged structure be regrown by just putting some paint on it? No. What you can do, hopefully, is prevent any more of it from growing diseased, because only new growth can make it right, essentially. Various ways to use nail paints, nail antifungal paints. Most methods agree, and they suggest that as much of the damaged infected nail should be removed with files, drills, etc. In my own opinion, and they perhaps don't stress this enough in the instructions with it, I think you need to remove the hard dorsal layer of the nail, because remember, the nail is in 3 layers, 3 lamina. So you've got the hard shiny layer on top, you've got the relatively thick middle layer, the intermediate layer, the humid layer, sometimes it's called. Then you've got the ventral layer, the one on the bottom, which is a bit like dry glue, and that actually stitches it down onto the tissue that the nail sits on, the nail bed. But certainly, if a nail paint is going to work, then I believe that you need to remove as much of the top layer as possible, and probably as much of the next layer as possible as well. Because if you do that, then you can actually use the exposed layer, the exposed nail plate, that is now no longer covered by a hard shiny surface. You can essentially use that as a wick. Now, hopefully that will then allow whatever you paint on it to permeate down towards into the root compartment, and hopefully clean out the fungal organisms that are down there. Because usually I think that is the way that fungally infected nails present. They actually grow up from the root. Now, I'm sure some of you are thinking, well, there is DLSO, distal and lateral subungual onychomycosis, which usually affects the end of the nail and sometimes the sides of the nail itself as well. So whether that's an infection that actually gets down into the root matrix, I don't know. Possibly that would respond quite quickly if the matrix isn't involved. It would respond quite quickly with antifungal nail paints. But usually you're going to need to get the active ingredient down into the root to do the maximum benefit. And as for removing it, you will note in some of the kits, these Amarolfine kits that they've got, like Curinail kits, you'll notice they put little tiny, and I do mean tiny, about so long, little files in there, cardboard files with a little bit of abrasive on them, which to my mind are about as much use as a chocolate teapot. If they're going to remove the actual nail top structure, you need something much more aggressive than that. Certainly, if it was a patient coming to me and they said, well, I want to use nail paint, then I'd get a drill on it. Now, that was something that before I started was pretty near 1/2 inch thick. It was a really, really malformed, deformed nail. So as you can see, I've ground it down way, way below, or way into the intermediate layer. And so that's absolutely perfectly ready now for this individual to start painting it with their Amarolfine. So very easy to remove, but be aggressive if you're going to remove it. Obviously, you have to take care that you don't remove some of the skin around it as well, which can be jolly painful. So that really then brings us on to systemic drugs. Now, systemic drugs are a bit of a minefield. Now, obviously, they are prescription-only medicines by their very definition. Those of you who are independent or supplementary prescribers can decide to prescribe these yourselves. Those of you who are not, and I would advise all of you to do your independent prescribing course. It really does help your practice enormously. But those of you who are not at the moment prescribers, you really have to ask the doctor or another suitable prescriber whether they would be kind enough to prescribe these drugs. And that can be where you run into a problem. 20 or 30 years ago, I don't know when, because I've never seen it, but some long time ago, in some medical journal somewhere in a galaxy far away, for all I know, there must have been an article discussing oral antifungal agents. And it seems to have frightened the hell out of the medical profession in general. Because with your average doctor, if you suggest that you would like an oral antifungal prescribed, they will throw their hands up in horror. They will cover their head up with a paper bag and they'll just wish you away. There seems to be an almost medicine-wide hatred and distrust of oral antifungal agents. Now, there's certainly things that you need to know what you're doing with, because there is a potential, sometimes a great potential for harm, but there's a potential for harm with virtually every drug we can prescribe. There's a potential for harm with antibiotics. There's a potential for harm with, virtually anything else you can say is a prescription-only medicine. It can go wrong and it can be misused. So you have to know what you're doing. You have to be aware of what you're doing. But try it yourself, just as an experiment. Ask your local doctor for an antifungal agent. And if they do turn around and say, yes, that's fine, and give you a prescription for it, then, please give them a gold star or something, because they're a very rare beast indeed. Naturally, I prescribe antifungal agents when I feel it is appropriate and clinically necessary, and it's of potential benefit to the patient. But I'll go through this in a bit more detail so that we can perhaps highlight some of the problems that may come about, just so that you're aware of it. And then if you do, for example, ask a doctor to prescribe some, then you've at least got some kind of framework in which to discuss it logically with the doctor. Possibly the earliest oral antifungal, or one of the earliest antifungal agents, was Gryseofulvin. And that's been kicking around for quite a long time. Now, if you look certainly in some of the older chiropody and podiatry texts, you will find that Gryseofulvin is anecdotally regarded as being pretty rubbish. It doesn't work very well. Now, that may be slightly unfair, because Gryseofulvin, or Gryseovin, which is another trade name for it, although I think the Gryseovin is actually a topical variation of it, because you can get a topical version of it. The Gryseofulvin has plus points because, first of all, it's licensed for use in children and in the elderly, and for people who've got moderate hepatic impairment, which means that even if they've got, if they do drink perhaps a little more than they should do, provided their liver function isn't seriously compromised, then this is something that can certainly be considered. Obviously, if it had a great potential for harm, it wouldn't be licensed for children, for example, or the elderly, because elderly very often have a much lower clearance rate of drugs, especially systemic drugs like antifungal agents, because antifungal agents, depending on the agent, they very often conflict with the cytochrome P450 in the liver, which is part of the clearance mechanism of it. And it can, in certain instances, if there's a buildup of the antifungal agent, it can interfere with the effectiveness or even the overall action of the cytochrome in the liver. So essentially, people will start to build up toxins in the liver, which of course is not good for man nor beast. It is, however, contraindicated in patients who are hypersensitive to the stuff, which of course is a no-brainer, because obviously you can say that about every medicine. People who've got iron problems, porphyria, people who've got severe hepatic impairment, so severe liver disease, systemic lupus erythematosus, it's contraindicated in as well. And also it's contraindicated, or it certainly has never been assessed for use in pregnancy and breastfeeding. But it's got quite a relatively flexible area in which you can prescribe that. Now, the one thing that is noticeable about glycofulvin is that in its summary of product characteristics, it says that it can be used for up to 12 months. Now, that's a hell of a long time to use a systemic drug in some people's perceptions. Certainly more years ago, when glycofulvin came out, we weren't quite such pill poppers as we are today. Well, of course, nowadays, I mean, a lot of people take a regular statin. They've done it for years. They'll take it for years, perhaps until the day they pass away. So we're not perhaps as anti as we were to take drugs over a long period of time. And I can't help but wonder whether some of the resistance to glycofulvin is the fact that people essentially didn't have the patience to keep on taking the stuff for nearly up to 12 months. So I've had patients who've gone on it for 12 months and they've reported good outcomes in several cases. And they're patients who, for some of the things that I put down there, they might be a little older than I would normally prescribe some of the other drugs for. They might be young people that, once again, I wouldn't normally prescribe some of the other drugs for, simply because I'd be going outside their terms of their license. And yes, the other drugs that we'll discuss in a moment, they do have UK licenses. So, for example, a prescriber can prescribe a drug off license or off label, as it's sometimes termed. But, and here's the big but with off label prescribing, it's not an unlicensed drug because it's got a UK license. But if you prescribe off label or off license, you need to be able to explain, worst case scenario, why you're prescribing it off label. Is there no alternative that's available within its summary product characteristics? Did you prescribe it in the full knowledge of what it could do? What precautions did you take, and so on and so on and so forth? Because if you did end up, for example, with a practice claim against you, then these are the kind of questions you would be asked in court if it came to that. And naturally, of course, you would have to have the answers ready for that. So you don't prescribe off-label lightly, but it can be prescribed off-label. They can be prescribed off-label if you want the other drugs that we're talking about, but I would have a care with them. But its label is so widespread, that it's quite a useful tool in your armory. And it's something, as I say, that I've resorted to, and I've resorted to with fairly good outcomes, fairly good results. But you have to sometimes keep on top of the patients, and when you come and review them every couple of months, 3 months, whatever, you say you're still taking the tablets, you're taking it every day, and so on and so forth. So if you can get good compliance, if you can get good concordance with the patient, then glycofulvin is worth looking at. And you might find possibly that if you're asking a doctor for the prescription, they may be more amenable to the idea of prescribing glycofulvin than they would be to something like Intraconazole. Now, Intraconazole, the presentation that we have is in 200 milligrams per tablet, is possibly the most potentially toxic and potentially has the greatest number of adverse events of all the current antifungal agents that we'd normally prescribe for onychomycosis. It is licensed for adults only. So if you use it for kids, you're using it off label. Would I use it off label for kids? Not on your bottom dollar. No, I wouldn't. You have to have care needed in patient selection. You need a full understanding of the potential pitfalls by the prescriber. The dosing regime, the posology in adults, is a little confusing as well. So you can either take one tablet once daily for 3 months, And during that time, anybody prescribing it would be well advised to have liver function tests kept on top of, and a liver function test before you start prescribing it as well. Alternatively, you can do it as what they call a pulsed medicine. Now, pulsed medicine is where you actually have a higher dose, so twice a day, 200 milligrams instead of once a day. But you do that for 7 days, and then you have a break, essentially, for 21 days, and then you repeat it. So for fingernails, you would repeat that twice, 2 courses. For toenails, 3 courses. So you'd have 3 pulse dosing regimes, or this one single regime. Is one to be preferred over the other? No, because they will both make the liver work a bit hard. Certainly the higher dose will, but then again, the liver, as we know, can regenerate itself quite happily if it's given a chance to. So the theory behind this is that if you give it as a pulse medication, then in the 21-day break, the liver has a chance to clear out the toxins that are built up, perhaps if the cytochrome P450 has been inhibited, and it can come back to a healthy state before you attack it again with another dose of Intraconazole. Trade name of that, by the way, Sporanax Pulse, the drug. Contraindications, absolute contraindications, are active liver disease, high caution in the elderly, any history of hepatotoxicity with any other drugs, and also susceptibility to congestive heart failure. So it's, a relatively potent substance we're looking at, including a number of things that you wouldn't encounter with the other drugs. Its plus points are that it has possibly the widest spectrum of action in various mycotic diseases. And I won't go through them all there, but as you can see, it ranges from vulvovaginal candidiasis, recurrent, to the prophylaxis of deep fungal infections in patients with hematological malignancy or undergoing bone marrow transplantation. So it can be a useful drug, but it's something that needs to be used with caution, with care, with knowledge, and also making sure that you keep absolute exemplary records of everything that you're doing. Side effects of Intraconazole, once again, Sporanax, the trade name. Common or very common side effects: alopecia, constipation, diarrhea, shortage of breath, gastrointestinal discomfort, headaches. Heart failure can be a common side effect of it. Liver disorders is a common side effect. Hyperbilirubinemia, in other words, a buildup of bilirubin. Nausea, edema, pulmonary edema. So, your lungs start to fill up with a bit of fluid. Various skin reactions, vision disorders, and probably in conjunction with the nausea, vomiting. So those are common or very common side effects. So you need a pretty powerful incentive, I think, to prescribe this stuff. And is, Mr. Jones's fungal toenails a powerful enough incentive to prescribe it? I have to say I err on the side of caution, but perhaps I'm a bit of a cowardly prescriber, because I like to do the best by my patients, but I also like to ensure that I don't do the worst by them. Uncommon side effects: hearing loss, altered taste, which is something to be avoided, of course, at this point in time, because if somebody's got altered taste and a cough, then they might worry very slightly. Rare or very rare angioedema, various hypersensitivities, vasculitis, which can be systemic, so systemic inflammation of the minor blood vessels. It can mess about with the lipids in your bloodstream. It can inflame your pancreas. You can become photosensitive, so you can go out in the sunlight and your skin can react to it. Leukopenia, buildup of white cells, abnormal sensations, tinnitus, urinary frequency increased, and so on and so forth. Potent stuff. It's got its place. Be aware of it, but as I say, it's something that needs great care. Then, kind of a middle of the road drug. And this is terbinafine, dear old terbinafine. Now, as you know, in its topical form, a brand name is Lamisil. If we're looking at its systemic presentation, then it's 250 milligrams, and the recommended dosage, the pathology of it would be in adults, 250 milligrams per day, omne dias, 1 day. The therapeutic indications of terbinafine tablets, which are now generic, they were quite expensive when they came out, but now that they've got the generic version, just the name, drug name only version, it's a lot cheaper than it used to be. So treatment of terbinafine sensitive fungal infections, for example, tinea corporis, tinea cruris, and tinea pedis. So you can use it for athlete's foot. The treatments of onychomycosis, of course, caused by dermatophytes, which is what we're talking about at this point in time. Interestingly, though, terbinafine tablets administered orally are not any good against pityriasis versicolor. It's completely ineffective against that. So it depends really the organism that you're trying to affect. But yeah, that's probably my second go-to after Gryzeophulvin. The duration of treatment for most patients using terbinafine is between 6 weeks and 3 months. I usually tell people to expect to be on it for 3 months, because 6 weeks, it probably isn't going to have much chance to get down into the matrix of the toenails. Sometimes you do have to put patients on it for longer. So I have had patients that I've kept on it for 6 months, but during that time, I'll always have kept a pretty close eye on the patient. I'll have ensured that there are ongoing liver function tests. It's nowhere near as toxic, in my opinion. Others may differ, but in my opinion, it's nowhere near as potentially toxic as Intraconazole. But nonetheless, it does have, the potential to cause liver dysfunction. So therefore, you do need to have access to liver function tests. Very simple blood test, very simple assay, and it'll come back almost invariably, yeah, the liver function's fine, which is sometimes a great surprise if the people then later on admit to, well, I'll get through about 3 bottles of whiskey a week. But that's it. You can never forecast, really. One person's liver might give up and die. Another person's liver on that diet, they might manage to survive on it. I don't know. It's worth pointing out once again to patients on it that, look, it won't do anything about the diseased nail that's already grown. You're stuck with that until some new nail grows out. So it can take several weeks or more before you get a complete resolution of the signs and the symptoms. But it's quite a useful drug. And if somebody doesn't respond orally to Gryzeophulvin, then this normally would be my next oral agent of choice. Dear old terbinafine. It tends to be terbinafine, rather more strangely than Intraconazole, that doctors have this almost systemic fear of. They say, well, it destroys your liver. No, I can't prescribe that. These are some of the contraindications. They're contraindicated for people with active liver disease. Liver function tests can be beneficial, as I've said. Well, beneficial, I think it's essential. If there is a toxicity condition of the liver, then it can occur in people with or without pre-existing liver disease. Or perhaps they might have liver disease, but nobody's ever picked it up before, which is probably a more likely scenario. Periodic monitoring, 4 to 6 weeks of treatment. After 4 to 6 weeks of treatment, via an LFT, a liver function test, is recommended. And of course, if the liver function test comes back as impaired, then you should discontinue immediately. There have been very rare cases of serious liver failure, and I think this is what must have been published in the medical press all those years ago. Some with a fatal outcome or requiring liver transplant. In my opinion, would that have been down primarily to terbinafine? No, that's my opinion, but obviously I'm willing to discuss that. Because I think in the majority of liver failure cases, possibly virtually all of the liver failure cases, the patients had serious underlying systemic conditions that were either diagnosed or not diagnosed. But obviously, the way that it was reported in the medical press, it has caused this systemic culture of fear amongst the doctors. I've been prescribing it for years in what I feel to be appropriate cases, and I've never had one case of impaired liver function during the course of it. There have been some people that I've refused to prescribe it for, after having done an assessment of them, and I'm talking about doing a verbal assessment of them, or looking at their medical records. I've never really encountered a situation where somebody thought their liver was fine, then they had a liver function test. I looked at it and said, I'm sorry, your liver's half dead. Never have that. But people who have, been counseled properly and assessed properly as suitable for treatment, I've never had one of those cases, touch wood, go bad yet. So I hope that hasn't broken my run of luck. These are some of the things you do have to consider when you're making prescribing decisions. The serum concentration of terbinafine, so the Cmax of it in the bloodstream, can be increased by more than 50% by concurrent administration of fluconazole, for example. Also, the area under the curve, the AUC, which is, once again, that is significant to serum concentration, which is the total drug exposure integrated over time. That could be more than 60%. So that will greatly affect the clearance of it. So once again, you don't want an affected clearance like that, because otherwise you'll be building up to toxic levels. If they're on rifamycin and somebody's talking, they can increase the clearance of terbinafine by 100%. So if they're in rifamycin, then that can make it completely ineffective. So they could be on it for a year and it wouldn't work. Caffeine, incidentally, if they're a bit of a, coffee addict or a strong tea addict, then caffeine can decrease the clearance of, decrease the clearance of terbinafine by 21%. So once again, you can get this build up. So you have to tell people, right, ease off the coffee, ease off the strong tea, and so on and so forth. There is a huge list of considerations at BNF, British National Formulary, or you can go on www.medicines.org.uk, which is the electronic medicines compendium. That's quite a good read on this. Now, I've been asked to include this because some of you who are loyal followers, and hello and thank you, loyal followers, might have responded to that competition that we had a short while ago about, there's a leg, it's a poorly leg, what do you think it is? Well, I can share with you that it was actually keratoacanthoma. And unfortunately, nobody actually sent that answer in. We had some quite interesting answers, but as far as I'm aware, and Jill can probably confirm this again, nobody came up with keratoacanthoma. And I've put a description there of keratoacanthoma from dermnet.nz. It's a website. It's a dermatology website. And if you want to brush up on your dermatology, I would strongly recommend going on to dermnet.nz. Huge resource of information. And it describes a keratoacanthoma there. There are different presentations of keratoacanthoma. It can be one of those things, it's quite hard to actually diagnose histologically, because very often if you take a sample of it and send it away, it'll come back and they'll say it's a squamous cell carcinoma. Well, not quite. No, it's not. But it's one of those things that seems to have some built-in unreliability. It's a bit like a vitamin B12 assay. If any of you send blood samples away for vitamin B12 assay, so often you'll get false negatives come back. Well, it's the same with if you send keratoacanthoma samples away, histology tissue samples, it'll come back rarely as a keratoacanthoma. The remarkable thing is they can disappear as fast as they come. I first encountered them in a dermatology department where I was doing some training, and they were actually on anywhere other than the legs. They were on the side of the face, they were on the backs of the hands, and the person who had them was in a terrible state when they came in. They came back for a 3-month review, and they completely cleared up spontaneously, which the dermatologist who was leading me through the paths of dermatology said they would, which I found pretty hard to believe. But they can resolve remarkably quickly. They can be removed surgically, but sometimes you're trying to run to keep still because they can erupt here and erupt there. So that's a keratoacanthoma, folks. So what about that thing that I showed you, first of all, on the very first slide of those nails? Jill or Kirsty, has anybody in the chat box come up with an answer for those nails?
Hi, Martin. No, we've not had anything as yet. So.
Okay, well, if let's come back to them.
Yep.
And have a look. There we go. So that's it. So nails with a green tinge. And the hint is in the green tinge. So if anybody would care to put an answer to that, and then just drop a line to Kirsty or Jill at head office and say, I think these nails are, I don't know, bubonic plague or whatever you think it could possibly be. And by the way, it's not actually bubonic plague. Then, you know, let's see what kind of answers come in, because these are things that you can frequently encounter, and you can see quite more severe presentations of that, where the nails really are, they just look green, as though they're growing grass under them. And you can get some very worried patients come in with these. So, you know, it's handy to have an answer for them, look at it and say, yes, that's so-and-so, because you will immediately become a hero to the patient. And there's nothing at all wrong with becoming a hero to the patients at all. It does you the world of good. And of course, you can make sure that you charge fees commensurate with being a hero. So there we are. I will leave you with that. Now, I've run over by 5 minutes. So once again, I'm going to get told off by Jill and Kirsty. Nonetheless, I'd like to thank you all for coming along. And I hope it's been of some use and some interest. If you have got any queries or any questions, then please do drop them along to head office. As you know, the Institute has got our Medicines and Procedures Committee, which is ably chaired by Gaynor, who's the chair of that committee. And we're always happy to answer questions that you might have on medicines or procedures. So if there's something we can help you with, or if there's a direction that we can point you in, we're more than happy to do so. So on that note, I'd like to wish you all good night. Thank you again for coming, and I'll look forward to touching base with you all next time. Good night.